What recommendations should HIV specialist clinicians make when they suspect that a patient is experiencing a serious mental disorder?
There's a very dramatically increased rate of psychiatric disorders in HIV clinics. So most providers are going to encounter psychiatric disorders that are serious. The most common condition is major depression. About 4% of people in the general public, about 20 to 25% of patients with HIV. So it's a very common disorder. Most of the patients are easily managed by primary clinicians, but a small subgroup are suicidal, hallucinated, delusional, or so psychiatrically ill that they can't cooperate. And for those people, you need consultation. And the recommendation for primary care clinicians doing HIV care is to at least have somebody that's the go-to person for those patients. More difficult to manage are conditions like bipolar disorder and schizophrenia. Bipolar disorder is a waxing and waning condition, so the patient can appear normal for quite some time, only to get incredibly ill all of a sudden. There's both a manic phase and a depressive phase. If you treat the depressive phase like the patient has depression, you'll often precipitate mania or a mixed state. And that's often how you learn that patients are bipolar. It's about 1% of the general population, probably doubled in HIV clinics. And those patients, usually you're going to treat with a consultant. You can treat major depression pretty easily. Bipolar disorder requires more expertise. And then schizophrenia, the problem with schizophrenia is that it is a very chronic mental illness. Patients are chronically impaired in terms of interacting with clinicians. They tend not to come for help. They tend to come in and out of care, and they do poorly with our treatment unless there's integrated health care. So for patients who have chronic mental illness, chronic bipolar disorder and schizophrenia, really integrated care where there's a psychiatric expert on site who you can interact with is the recommendation. Now, making that happen in our current environment is very difficult, but it is the best way to do it, and there's several studies that show that if you have integrated care for substance abuse, mental health, and HIV, you have much better outcomes. So making that happen as virtually as you can by having somebody that you work with fairly closely for patients with chronic mental illness is ideal. Last thing about chronically mentally ill patients is that experienced providers who are willing to work with them and work well with them are useful to have as a person who they go to. So the problem with schizophrenia in general is the patients get poor medical care because most clinicians are very pressed for time. They want to see those patients in the same time frame as they would see an ordinary patient. Those patients take much longer. They need more resources and they have more issues. So when a clinician goes in to see a patient with schizophrenia, they have to accept the fact that they're going to spend more time and they have to be cognizant of the disorder. Patients with schizophrenia in general are paranoid. They have ideas called ideas of reference. They have ideas that things you're saying are about them in ways that you don't intend them. And those patients really require some special handling.